and then let everyone in.
Then I'll admit everybody. Okay.
Okay, well, welcome back everyone. And it is Monday today and not Tuesday, so I can redeem myself. Hope everyone is doing well no matter what time of the day that it is. Alec and I again are excited to be back to discuss a case, and Rahul is going to present one to us. So Rahul, if you just want to unmute and introduce yourself a little bit again, that would be great.
Absolutely. Hello, guys. Hello, everyone. Good morning, good afternoon, good evening, wherever you are. I'm Rahul. I'm currently started rotation at Yale Waterbury Hospital in internal medicine, and I'm excited to share this case today. And outside of medicine, I cook a lot. I cook a lot of Indian cuisines. I try variety of different recipes, and I also do practicing guided meditation and yoga. Yeah, those are my hobbies.
Very, very cool. And I've attempted to make Indian food before, but I'm definitely not the spice master, and I feel like I burn the spices when I try to toast them. So it's like truly a delicate art, kind of masterful Indian food. So one time I'll have to find you and you'll have to cook for me to teach me about how to do it.
Absolutely, absolutely.
Okay. And
Or else
then
I'll
I
fly to
think,
Texas and I'll make something
yes,
for you.
yes, I'll have to save up and book you a flight so you can come down and stay with me. Very good. Okay, and I think Parisa and Gerardo are helping with the teaching points and scribing today. So if you guys want to introduce yourself, that'd be great too.
Hello, everyone. This is Parisa. I'm doing teaching point today, and I'm so excited for today's case.
And hello, everyone. My name is Gerardo Luna Peralta, and I'm a med student, and today I'll do the scribing. Yeah, I'm excited for today's case.
And thank you to you both. And so whenever we're ready, we can get the whiteboard up and get started.
Shall we start? All right. So here's my first aliquot. He's a 38-year-old male without significant past medical history, presents with shortness of breath since 20 days, which was insidious in onset and gradually progressed. So he was not able to perform his minimal activities like even and like such as wearing clothes. And he also complained of easy fatigability for 30 days and swelling of both feet since 20 days. This is my end of first aliquot.
Okay, thank you so much, Rahul. Excellent start. So we have a fairly young gentleman coming in with what I'm going to describe as subacute progressive dyspnea. And I think, like many, I anchor myself in the dyspnea pyramid, with cardiopulmonary causes being sort of 90% of the causes of this chief complaint. But there's other things that can, sprinkle in there: endocrine disorders, acid-base disorders, anemia, diaphragmatic issues, and other things, neuromuscular weakness and other things related to that. But I don't. Oftentimes, when I find myself in the space of subacute dyspnea, I'm really running towards heart failure. Just as a hospitalist, it's something that I see very commonly. About it sort of just gradually starts, gets worse and worse and worse, so much to the point where the patients are unable to, do their ADLs. Normally, they get up, they walk to the bathroom, they don't have any problems, and then they notice that it's hard to bend down and tie their shoes. I think we're getting sort of the flavor of this. And then we find as well that there's some associated swelling that frequently I associate with heart failure as well. So I think is, just my type 1 thinking. That's the first thing that comes to mind, but certainly I don't want to anchor on that. So I think I would be exploring the etiologies of dyspnea, particularly a dyspnea on exertion. And then the etiologies of lower extremity edema as well, and things that can overlap with that. So primarily basing myself, in the cardiac system, just by base rate, but noting endocrine issues, kidney issues, liver issues, and things of the sort can, work our way to solve that. I think Robbie does this really well, and he really has to listen to how the patients describe the symptoms and what weight they put to each one. And just based off the way Rahul has said this, it's dyspnea and then everything else is like a little bit less. So I think I'm going to be solving that first, and then looking to overlap the swelling and incorporate that later on. But these are my initial thoughts. So, I think for a lot of the dyspnea and other things, we can sort of attempt to clarify if there are any other associated symptoms, something that the patient is this something that they had before? Is there an inflammatory component to the syndrome that's ongoing? It is a fairly young patient. So if it does turn out to be related to cardiac issues, we're going to have to figure out exactly what's driving that. But these are my initial thoughts, and I would love to hear how Austin layers in on this. I imagine he might see something like this in the clinic from time to time.
Yeah, no, excellent thoughts. I really don't have much to add to that. I think right now we are solving kind of the subacute dyspnea plus edema overlap is how I'm sort of thinking about it. And since they seem to have started at the same time, that may be a mistake to make that jump. But I think for now, that's where my headspace is. And if you think about the causes of edema and overlap, subacute sort of progressive dyspnea, we think about the heart and how that's a really, really good fit, as you mentioned so far. We can think about the liver, and there are certainly ways to invoke how we could have the liver be implicated in this process, though. Usually dyspnea is, by the time you get to the point of dyspnea, you usually have other features that are going on that maybe the patient is not mentioning at this point, but we'll see from the history if that can guide us one direction. But I think that would be a little bit lower. And then same with the kidneys, there's certainly ways to invoke edema and dyspnea in the form of renal dysfunction in a subacute fashion potentially. But again, I think there'll be other features of the case that could point us in that direction depending on how things go. I think what if I had to ask for something right now to help, how it could help me with those buckets, maybe the blood pressure. I think something that's maybe I didn't appreciate before, that, if the patient's really hypertensive, that might push us one direction. If the patient's blood pressure is relatively on the lower side, that might push us in another direction. So we'll see, but really, I think where you're at with your headspace right now, I can't really advance further than that. So I think the patient's age is, such that sort of our traditional thinking of why someone might have heart failure are maybe slightly less than we would expect, depending on the patient's kind of other past medical history and family history. But I think that's more of a VMR bias than anything else. So yeah, Rahul, let's get the next aliquot and go from there.
Absolute. Great discussion. Once again. Yeah, as far as HPI is considered, and he complains no nocturnal awakening due to shortness of breath and no shortness of breath on lying down, no chest pain, no palpitations, syncopal attacks, and patient developed swelling of the both foot. Insidious in onset, it is gradually progressed and extended up to his knees from the past 20 days. And swelling of the foot not subsided with the rest, and it got relieved with oral furosemide. Patient noticed blackish discoloration of stool 2 to 3 episodes per day for 3 days. Stools were sticky, malodorous at the time, and history of bleeding gums present for 2 days and then subsided. The review of systems were otherwise unremarkable. Coming to the past history, he's a known case of hypothyroidism on thyroxine of 50 milligrams, 50 micrograms, but is poorly compliant to medication. He's also recently diagnosed with diabetes 1 month ago and started on metformin 500 mg BID. No surgical history, no family history, personal history. He takes a balanced diet and is a known alcohol use disorder for 8 years. And he takes around 80 to 180 ml of alcohol per day. And he's a smoker. I think he smoked around 7 to 8 years and smoked 2 to 3 cigarettes per day. And he also chewed tobacco. And as far as examinations of vitals are considered, he is febrile, pulse rate is 106, blood pressure is 110/80, respiration rate is 14, and patient is fine, he's conscious, coherent, and cooperative, and moderately built and nourished, BMI of 21, pallor is present on exam, pedal edema is present and it's spitting in nature and up to the level of knees, and no icterus, no cyanosis, and no clubbing and lymphadenopathy. Alopecia is positive, and graying of hair is positive, and rest of the rest of the examination is fine. And on thyroid exam, on inspection, there is 6 into 4 centimeter swelling noted in the neck region without any nodularity. Swelling most with the deglutition. On palpation, there is swelling of 7 to 4 centimeter, which is firm in consistency. Margins are smooth, not associated with nodules, and no sinuses, no fistula, no audible bruit, no signs of thyroid ophthalmopathy. GI, CVS, and respiratory systems are fine. This is the end of my second aliquot. It's very extensive.
Yeah, no, a rich aliquot with lots of information, and I think I tried to capture that. And so, Alec, maybe I will touch on kind of the review of systems in the past medical history, and then have you go through the vitals and the physical exam, and we can chime in go back and forth or dance, as Robbie and I like to say. I think in the review of systems, we heard about no obvious orthopnea or paroxysmal nocturnal dyspnea or nighttime awakenings, and so that might make us step back and think about, hey, is the heart really on the hook here? And then this is where we start to get a little bit of another flavor of something else happening in the background, which is these dark stools for the last few days, as well as what seems like mucosal bleeding in the GI tract, as well as in the oral mucosa, which I guess would involve technically be a part of the GI tract as well, depending on how you think about it. And so how can we take a step back and say, hey, the subacute progressive dyspnea we were thinking about with the edema associated with it, the heart as the overlap, but maybe a progressive anemia is really what's at play. And the fact that it's been going for 20 days was that it was more occult in the form of iron deficiency, if we're able to check this patient's labs a few months ago, to now where we're seeing more overt bleeding because there is some sort of progressive issue, probably with the coagulation cascade. And given the mucosal nature of the bleeding, would probably make me think either a platelet number problem or a platelet function problem is where my mind is at right now, though there could be other aspects of the coagulation cascade that would be affected. So now that we have that piece of information to incorporate, how can we overlap that with edema? And I think one way to do that is to say, if we're having bleeding in the GI tract, maybe there is concurrently as a process of that, like a malabsorptive problem. I think that's one way to potentially overlap it. The other way is to think again through the causes of lower extremity edema and see which ones are associated with a thrombocytopenia potentially. And I think the liver is one that could definitely be on the hook, and in particular with this person's kind of rich health-related behavior history, that's something that would be at play. I'm sad to say that a patient at 38 is not the youngest patient I've ever seen with a massive GI bleed from cirrhosis. And so certainly that could definitely be implicated here. As far as the other histories, we have the thyroid, we have the new onset diabetes. How can we put these things together? I think base rate would say that these types of conditions are common, and so we shouldn't necessarily lump them together. But when I see the kind of alopecia that was later described in the exam, and it'll be interesting to get some more history on that, the new onset diabetes with hypothyroidism, it always makes me think about the sort of, if you have one autoimmune disease, you're predisposed to have yet another autoimmune disease. And then these like polyglandular autoimmune syndromes, of which I really don't have a great recollection of them, but diabetes, thyroid disease, and then usually the adrenals go together in one of the forms. And so that would make me step back and think about, is this something I would need to think about? Otherwise, someone that has a rich alcohol use history, if they had prior bouts of pancreatitis or something like that, then that might explain why the patient could have diabetes, and understanding how the diabetes would diagnose would be helpful as well. So I think there's a lot of threads to pull on I'm talking a lot of different ways. I'm trying to go back to the patient's chief concern, which in medicine, when things get really hectic, especially in the clinic, sometimes this happens. The patient will say, have 5 or 6 or more different things that are really bothering them. And you'll go and do labs and find a bunch of different things, but none of them are really what the patient was worried about in the first place. So always go back and say, hey, what was the patient's chief concern? Why did they come here? And really make sure that your evaluation is working to address whatever that is. And so now I'll have Alec go through the, chime in on anything else and go through the files and the exam.
No, that was excellent, Austin. And honestly, even in that moment, I wasn't really pulling together the idea of, autoimmune polyglandular syndrome. So that's just amazing that you even thought about that so early on, just trying to connect the dots. And yeah, I think this patient, just going through the additional history seems to have some autoimmune propensity. The alopecia, it's hard to know if that's sort of autoimmune in of itself or just related to his hypothyroidism that may currently be uncontrolled. It seems like his adherence to the medication was a little bit unclear. And then it seems like the patient has a very significant alcohol use disorder history. And, with the melanoma and other things, I think you did an excellent job thinking about how that we may link that to more sort of chronically unrecognized liver disease. And so I think, I don't think I caught the entire physical exam, but I would love to know, what stigmata of cirrhosis there were, if any. It seems like in the past he had sort of a transient episode of jaundice that resolved, and I'm not sure if he had a acute hepatitis from alcohol or something else potentially that self-resolved, or maybe it was infection or medication related. So a bit unclear, but I certainly, when I would be examining the patient, I would be definitely looking to see what stigmata of cirrhosis the patient had. So in addition to the edema, am I seeing pulmonary edema, telangiectasia / spider angiomas, looking for the jaundice, some other things, and seeing how pale the patient is with our concern for anemia that you sort of astutely pointed out as well. And I think something as well that I think about in patients that have liver disease, and because I think anchoring ourselves initially in the base rate of heart failure, I don't necessarily think that was the wrong thing to do, but I think the lack of orthopnea is a little peculiar. But then sometimes you can really get humbled by isolated right-sided heart failure in particular, where you just get more edematous and less orthopnea, and sometimes in those situations, at least in my experience. And certainly cirrhosis has numerous mechanisms in a way that it can lead to that. But again, I don't want to anchor myself in that, and I think the differential remains broad. But we're sort of, like you said, we're getting pulled in many different ways. So I think having missed some of the exam, I'd definitely be looking for JVP in addition to stigmata of cirrhosis, be looking for the jaundice, be looking for asterixis, be looking for, other signs. Is the patient actively bleeding now or not? And when we're solving the edema, certainly, Robbie just says, look up, right? You see the edema lysated to the legs. It may be suggesting more of kidney disease, but it seems like we're getting flavor of the liver, and then even more so potentially of the right heart, or everything combined. So I'm looking forward to getting more details upon that. And the thyroid exam, I don't think I see that documented, but it seems like the thyroid was quite enlarged. It seemed to be firm but smooth. There weren't any parts that were larger than others. We didn't get a history that the patient had any dysphagia. Could it be that the dyspnea in part could be related to that? Although oftentimes, if it's from the thyroid, I would have expected some orthopnea, which is potentially from a compression of the thyroid onto the trachea. But it's, for me, honestly, I'm still trying to solve the dyspnea and a subacute dyspnea and edema overlap. And the thyroid, I'm just sort of saying this patient probably has a goiter potentially related to, his undertreated hypothyroidism. And I'm not sure how much cognitive energy to place into that. One, because I still feel like dyspnea is more important to solve it this time based off his symptoms. And two, I just have a less comfortable illness script for that. So, and so I think for now, besides really getting a sense of, can we get some signals on exam for where this edema may be coming from? And then, are there positive signs on the pulmonary exam or the cardiac exam that may point us in one of those two directions? But definitely getting a flavor of potentially liver disease, the chronicity of which is a little bit unclear at this point. And then, getting a sense of Are there acute complications related to that, or does the patient have multiple things going on? So, I'm certainly looking forward to the labs and some clarification on the exam. But it seems like, patient is mildly tachycardic, but otherwise stable. And I think we have a little bit of time to solve this because it took a little bit of time for him to present. But certainly, if the patient, could acutely decompensate if he does indeed have another bleed. And yeah, I think those are my initial thoughts. I've done a lot of rambling. I guess the only other thing I might add based off the history, it seems like he has some CV risk factors, but hasn't really lived long enough, seemingly, to have them predispose him to, significant, atherosclerotic disease. And, could be, I was wondering if the patient might be more predisposed to MASLD or something like this, but he's quite young. His BMI is on the lower side, but this is a wide spectrum of disease that I don't, I know that I can present in variable ways, but just another thing I was thinking about. But also, I'd love to hear if you had any additional thoughts on the exam, and then we can get more information from Rahul.
No, really nothing else. I think the oral exam, just seeing if and on the skin exam, if there are signs of petechiae or if there's obvious mucosal bleeding in someone that has, maybe the potential for, it sounds like his diet was relatively okay, but if we're invoking like a bleeding disorder, then, just looking for any signs of malnutrition in other places. So looking at the nails, looking inside the mouth, looking for any rashes, those would be potentially useful things to do in high yield. The stigmata of cirrhosis, as you alluded to, the JVP, which I may have missed, that will be helpful as well. And then it was happenstance. I didn't get to go to the rapid fire VMR today, but it was like while I was there, I was seeing a patient that was having just fatigue, and I looked at her eyelids, and they had a lot of pallor. So in particular, we talk about conjunctival pallor, but really it becomes more nuanced because when you pull the conjunctiva down, you'll often see an area that is more bright or has a lot of blood flow in the posterior. So really, when we're invoking conjunctival pallor with a good likelihood ratio of suggesting anemia, then that you're looking at the anterior conjunctival rim. That's really the area that you're looking for. And so a nice full circle moment today. So I'm curious to see what the blood counts show. I'm curious to see what the platelets show, and then trying to pull on the thread of coagulopathy. And if there's no anemia here, I think it really is going to reshift our focus back to the dyspnea and why the patient came in the first place, and go from there. So excited to learn more, Rahul.
Yeah, wonderful discussion. I really loved it. Coming to my third aliquot, CBC of hemoglobin of 5, MCV of 90, MCH of 29.5, MCHC of 32.2, white count of 3,300, platelet count of 12,000, reti count is 0.5%, absolute reti count is 0.1, reticulocyte index is 0.05. Coming to the CMP, blood urinate BUN is 27, serum creatinine of 0.59, sodium of 129, potassium of 4.9, chloride of 99, total bili 2.2, ALT 40, AST 48, alkaline phosphate is 69, total protein 6.5, serum albumin 3.5, globulin of 3.3, CRP negative, and ESR is 22 in first hour. Coming to thyroid profile, T3 is 99.65, T4 of 8.7, TSH of 7.8. And as far as diabetic workup is considered, his A1C is 7.5, fasting blood sugar 140, and post-lunch blood sugar 215. That is the end of my third aliquot.
Oh, excellent. Thank you, Rahul. And just to clarify, the T4 and the T3 that you mentioned, do you know the reference ranges for your lab? Were those high or were those low?
Yes, they are normal, except TSH. T3 and T4 are normal, except TSH.
Okay, excellent. Thank you so much for clarifying. So, just to briefly summarize, the patient has pancytopenia with very significant anemia, although we don't have a baseline to know what he was previously, and then very significant thrombocytopenia to 12. The MCV is 90. And it doesn't seem like his bone marrow is responding appropriately because the reticulocyte index is less than 2. So, I think whenever I see anemia and thrombocytopenia together, I certainly look at the kidney function and need to think about if I'm missing a TMA or, a TTP or a syndrome related to that. And also, anytime I think of anemia, I see anemia and thrombocytopenia concurrently, I'm definitely thinking about liver disease and portal hypertension. And I think that's something that is still pretty high on my differential at this point. And so, Robbie, he thinks about pancytopenia with his 4 S's, which I think is a systemic syndrome, a stem cell disorder, a substance, and then, oh gosh, Austin, you're gonna have to help me. I think I forgot the last one.
It's like stuff or space.
Stuff, yeah,
occupying,
stuff.
yeah.
And then I actually add a 5th, which is splenomegaly, because I never really know where to put it. So, the more cell lines that are involved, the more you have to think about the bone marrow. But, particularly in cirrhosis, you can get a lot of portal hypertension, and the spleen can just hold on to everything. So I hate to anchor myself in there, but the presentation, with sort of a subacute progressive dyspnea on top of a little bit of jaundice and edema, and with a likely, melena is certainly very concerning for that. And then on the BMP in particular, the BUN to creatinine ratio is profound. His creatinine is 0.6 and the BUN is 57, if I remember that correctly. So the BUN can be high for a few different reasons. There's blood, and there's like a couple, great curious clinician episodes on why the BUN goes up.
I think the BUN was 27, but
Okay.
in someone that is this cachectic and wasted, and probably not of the best nourishment or even liver disease, I agree with. I think your teaching points are very good. So keep going.
Sorry, I thought I heard 57, so apologies for that. But yes, the ratio would still be quite elevated, greater than 35. So suggestive of some intravascular volume depletion and then the blood breaking down. And certainly we need to figure out exactly why is that. And then the BUN can also be high if people are on steroids or they're in a catabolic state, or you're giving them a lot of protein, which sometimes you see in the ICU when you start to feed people again. And then I think I missed coags if we got them, but I certainly would be curious to get those. The smear, I would love to know if there are schistocytes, sort of any elliptocytes, or there's like a significant difference in the size of the red blood cells, or any other things that we might see in liver disease, like spur cells or anything like that nature. The albumin is a little bit higher than I would expect for somebody with, I'm invoking has a lot of liver dysfunction, but they may be intravascular volume depleted, and I would need to see where that shapes out afterwards. I'm not really sure what to do with the inflammatory markers. I'm not sure they're contributing all that much to my thought process, but it seems like the ESR for the person's age, it's not really all that concerning. And the thyroid profile, the TSH is mildly elevated. But the T4 and T3 are okay. So it seems like maybe he's not fully adherent to his medication, but I'm not sure that that's driving the patient's current presentation. It doesn't seem like the TSH would be consistent with the mixed edema, and I don't think the patient's presentation is really all that consistent with that as well. And seems like the diabetes workup, the fasting sugar was 140, so above the 126. I didn't hear an A1C. Oh, sorry, A1C was 7.5, so not that bad. But certainly something that we'll need to figure out why he has it, and see how well his disease has been controlled. And thinking about it, could this also be an auto immune etiology, or like you astutely noted, could it be related to sort of pancreatic endocrine insufficiency related to alcohol use disorder? So the hyponatremia is mild now that I'm seeing the labs here. Probably I would resuscitate the patient and then worry about it later if it actually stays low. Yeah, I think these are my initial thoughts. The pancytopenia, which we'll need to solve, I think I'm relating it to sort of portal hypertension and potential systemic disorder there. But we would have to run through all the buckets. Certainly, I would want to clarify his alcohol use disorder history. It seems like 180 mils every day. I would love to know what he's what he eats diet-wise, or if he spend the majority of his time drinking, because these patients can be significantly nutrient deficient. And he could have multiple nutrient deficiencies that could be driving some of his cytopenias as well. And then, like Austin noted astutely as well, with the bleeding, certainly the thrombocytopenia would explain some of the mucosal bleeding, but could there also be a vascular integrity issue with vitamin C deficiency or something else? And I think this is a patient as well that I would just empirically be giving thiamine just to be sure that once we're resuscitating the patient and he may start to eat again, that we're not going to be inducing Wernicke's. And then, supplementing the vitamins if necessary as well to be sure that they're able to make red blood cells, because that may be in part he doesn't actually have the building blocks to do so. So, yeah, I think those are my initial thoughts. And, I think, Austin, as far as like where I would take things from there, with the bilirubin elevation, I guess I would love to know if it's direct or indirect. I don't feel like I'm getting a flavor of hemolysis, but I would need to exclude that at this time as well. But I certainly would be probably transfusing the patient, definitely running to imaging of the liver to try and see if this is on the hook or not, and then going back to the exam to try and confirm some of this. And then with the BUN to creatinine ratio, I would definitely, be trending that and probably treating the patient as if he had an upper GI bleed, with the thought of this, if this could be liver related, being sure that the patient gets the appropriate medications, including antibiotics, octreotide, and probably a PPI as well. But I feel like that was somewhat scattered, but I'd love to know how you're processing this information, Austin.
No, it's very, very good. I think, we sort of have a pivot point in the sense that we have a deep pancytopenia. And I think from the history, we have a sense that this is not acute. There's at least a subacute, maybe even a chronic tail to this. And I think that is suggested by the fact that this patient's hemoglobin is 5 and they have a heart rate of 106. And then also, it takes time to get conjunctival pallor typically. And then also, the MCV is 90. If I think about why, someone that has iron deficiency anemia, what type their MCV is, usually it's low. And so I think there's 2 ways to reconcile this. Actually, there's probably more than that, but the way I'm thinking about it in my mind is, okay, so we should expect to see that the patient has a low MCV. So why is it 90? Why is it normal? So one is the concurrent alcohol use disorder. That's one way to invoke it. One is the hypothyroidism, though in my clinical experience, I've treated a lot of patients with thyroid disease, ordered thousands of TSHs, which have been normal most of the time. And then, never really seen macrocytosis from thyroid disease. Like it's not something that I really see. And so maybe others know, but I've never actually looked up the performance characteristics of that, but in my clinical experience, it seems like it's probably low. So if I'm seeing a normal NCV when I expect it not to be normal, then there's some sort of concurrent process, second process going on, at least one. So I think for this patient, we talked about vitamin deficiencies, so that definitely be at play. We want to make sure that there's no hemolysis going on, which there's subtle signals too, potentially. So rounding out the hemolysis labs would be something that I would probably add as well. And then, if we're not getting to a clear answer between the imaging and the additional blood work, then I think we're going to have to run towards a bone marrow biopsy here after we do some, basic secondary evaluation as far as why this happens. Doing looking for, basic vitamin testing like a B12, something like that. And if all of those come back and we don't really find a whole lot, then I think, the bone marrow is on the hook and we'll have to go from there. So Rahul, excited to hear your next aliquot.
Wonderful. Coming to my 4th aliquot, peripheral blood smear shows anisopolygocytosis, normocytic normochromic RBCs, macrocytes, and ovalycytes are positive. White count is decreased with lymphocytosis with few hypersegmented neutrophils. Platelets very low and scattered discretely and no clumps seen. No evidence of atypical cells or hemoparasites. As far as iron studies are considered, serum iron of 9.6, total iron binding capacity of 476, transferrin saturation 2%, transferrin of 30. Serum B12 is 160. Direct and indirect Coombs test is negative. and serum LDH is 4210. As per as infectious workup, Vidal test for typhoid, HIV, HBsAg, hepatitis C, dengue NS1 antigen, and HSV, EBV, CMV, parvovirus antibodies are negative. This is the end of my fourth aliquot.
Okay, so Alec, I think you had to step away, so I'll just summarize everything. We had a smear that showed macrocytosis, or sorry, macrocytes and ovalocytes, as well as some lymphocytes and some a few hypersegmented neutrophils, but no atypical cells, no parasites. And there was some iron studies that showed a TSAT of 2%. They had a B12 that was low at 160, a negative Coombs test, and an LDH that was mildly elevated at 421. And then some infectious studies, which were quite robust, including many viral serologies, including HIV, hepatitis C, hepatitis B, EBV, CMV, HSV, all of those were negative. And so I'm going to leave the ovalocytes to you because I actually don't have a good approach for that or know what that means, to be honest. So I'm going to leave that one to you. It doesn't seem like we're seeing the marrow crying here in the sense of the dacrocytes, but would certainly be a consideration. We are seeing the lymphocyte population, and Rahul, I don't know if on the CBC there was a differential, like what the absolute lymphocyte count was or what the percentage was.
Absolutely. 1 second, just give me a second. Yeah, neutrophils of 45, lymphocytes of 32, and monocytes of 19, eosinophils of 1, basophils of 0.
Got you. Okay, yeah. So it didn't really seem particularly deranged, but they did comment on some lymphocytes in the periphery, as well as some hypersegmented neutrophils. So based off a case, gosh, I forget which day it was last week, that we had a case that Robbie was discussing, and there was a patient that had lymphocytes in the periphery, and we were worried about, could these represent blasts or not? And now that we're seeing the lymphocytes here and these hypersegmented neutrophils, are some of these cells being pushed out of the marrow, or are they reactive? We're not seeing any atypia on the cells that were visualized, but it does make me think, hey, is there something in the bone marrow that we need to be invoking? And so we kind of alluded to the fact if the kind of initial workup was negative, we would be heading towards a bone marrow biopsy, but maybe that lends a little bit of credence to that as well. Like, is there something within the marrow that's infiltrating and pushing things out that we aren't supposed to see in the periphery? Or is that we're having such dysfunction or dysregulation of how cells are being made in the marrow because we have nutritional deficiencies, and that's why we're seeing some of these cells come out, in particular like the hypersegmented neutrophils. As far as the other studies, we have concurrent iron deficiency, which is profound at a TSAT of 2%. We want total ferritin, but in this particular case, maybe we're not really getting a lot of signals of inflammation, but even if it was high, the patient has iron deficiency, there's no question about that. And then the B12 is also low. So whenever I see that overlap, certainly you can have low B12 and bleeding phenomena that happens. But I think the other thing you have to invoke when you have multiple vitamin deficiencies for any patient is that, is there some issue with absorption? So sometimes it's an intake problem, but at least in the United States, food is so abundant, and we fortify a lot of foods that usually low intake alone is not enough to cause vitamin deficiencies in the absence of like alcohol use disorder. It's pretty much, I've never seen folate deficiency. I hope I never will. And in the United States, it's so uncommon that multiple institutions that I've worked at have removed being able to even test for folate because number one, it's a bad test, and number two, it's so rare that usually we would never find it, and it's just easier to treat empirically for the most part. So I think, is there a malabsorption problem happening? And then we do have, signals for malnutrition, as we've already talked about before, so I won't belabor that, but something for us to think about if we need to go looking in the GI tract. We have an LDH that's elevated. I think that could speak to abnormal cell turnover. We're not really seeing, again, any sort of overt signs of acute liver injury on top of likely chronic liver injury that exists here. So it's hard to say that the lung or the liver or hemolysis is really at play based off of the blood work. So that makes me think of are there, again, going back to the marrow, are there cells coming out that are a little bit more fragile? And that's where we're seeing a leak of LDH. And, this is not an uncommon phenomenon that you can see in, more profound B12 deficiency. Going back to the malabsorption issue that I touched on before, but didn't finish my thoughts, was that the combination of iron deficiency and B12 deficiency in my mind should always make us invoke the possibility of pernicious anemia, especially in a patient that has multiple autoimmune predispositions. And if I recall correctly, pernicious anemia is part of the one of the autoimmune polyglandular syndromes. Again, people that are closer to step one, hopefully they know better than me about this, but that is a link that had just come to me right now. And then I think the excellent, viral infectious serology testing was important to make sure that, if we're going to see imaging suggesting liver disease, why the patient has liver disease, but also why they have this pancytopenia. So those are my thoughts. Alec, what thoughts do you have?
Not much, Austin. That was amazing, incredibly thoughtful about things. And I totally agree. The valicytes, I don't have a lot of experience either, but I will say, when I see sort of multiple different abnormal cell types and the anisopoikilocytosis, just meaning that the red cells are just different in size, it's just usually the bone marrow just doesn't have what it needs to get well, or the patient has liver disease. And I think there's certainly already have a signal for that the patient doesn't have the nutrients that they need to, produce healthy cells, because the iron is very deficient. Although it would be great to have the ferritin, and the B12 is quite low. And in addition, like with the lipid disorders that sort of can cause, you can get sort of some abnormal cells and elliptocytes and other things. And so I am still quite concerned that the patient has underlying liver disease, but the severity of which is we need to clarify. And I would also love to know what the coags are. And before I further my discussion, I just want to clarify the LDH. I think I was seeing on the board that 4,000 was written. Is it 4,000 or is it 400?
It's 4,000.
4,000. Okay. So very, very, very high. I think anytime I see an LDH that high, there's massive cell turnover going on. So I've seen that in acute, liver injury / failure before. But the liver chemistry tests themselves, like the AST and the ALT, are not that remarkably elevated, not to explain that. Definitely you have to think about leukemia, lymphomas with an LDH that elevated as well. Massive pulmonary injury, like really bad sepsis, other things. But certainly at this point with an LDH that high, we have to sort of really be going towards the bone marrow more so than I was before. And so although we don't see the presence of schistocytes there, the smears are imperfect, and you have to be able to find the right, if it's an automated, they may miss them, or like Reza says all the time, you just need one schistocyte in the right context to be too many schistocytes. So I think that because the patient has anemia and thrombocytopenia, the retic count is inappropriately low, but the patient has severe B12 deficiency. So you need to really think about the possibility of a pseudo-TMA. The Coombs tests are negative. I don't think we got a haptoglobin, so I would definitely be interested to see what the haptoglobin is. But I would be repeating the smear, going there to look at it myself, just to ask somebody else if they see anything, considering involving the hematology colleagues, and then really trying to figure out what else could be driving his LDH. But right now, the process that seems most likely is something going on with the hematologic or reticular endothelial system. So, I think I would sort of further the idea that the patient may have ongoing intravascular hemolysis with the idea of getting a haptoglobin. The retic count being low is somewhat atypical, but something that you might see in a patient that has severe B12 deficiency. And it could play in the cytopenias and other things. But I would also really want to know what the coags are, get a fibrinogen as well, and, to be sure that the patient doesn't have DIC and are not missing that. And, the smear, again, just repeating that as well. The infectious workup seems like the majority of the viral illnesses that could cause maybe some subacute diseases have been ruled out. But I would also be, thinking about things that granulomatous diseases that may cause more sneaky things that can infiltrate the bone marrow, but seems a little bit less consistent because we really don't get much of an inflammatory signature otherwise at this time. And Austin, like your idea of, autoimmune gastritis, I think is just amazing. And I learned recently that a lot of the times with autoimmune gastritis, like the sort of association that people often learn and that I learned in medical school was primarily with pernicious anemia, but iron deficiency is actually probably more common. And certainly the patient potentially has both. Though the the ferritin is 5,000, the iron sat can be a little bit more difficult to interpret. So I know I missed some of this, but I think at this time I would probably be repeating the smear. I would be getting a haptoglobin, getting the coags, probably getting a fibrinogen, you know, replacing these patients' vitamins. So, if it is a nutritional issue that's preventing the patient from making the cells that they really need, that they would have all those vitamins available to them. And we have probably reached the point where I would be asking our hematology colleagues to help. But I still can't remove the idea that the patient may have underlying liver pathology. But now that I think about it more, like, could the patient have had melena just because they bled in their mouth because of the thrombocytopenia and then pooped out black poop? And it's possible. But I also don't want to miss that diagnosis just because of the morbidity and mortality associated with that. So I still think that would be important to do. And I think also if we find splenomegaly in particular, it might make us run more towards hematologic malignancy in particular. But the absence of fevers or other sort of inflammatory signature is peculiar. And Austin, I think on the last aliquot, how you surgery astutely mentioned that that the anemia isn't acute because the heart rate is 106 is just another profound recognition about how tempo is so clean here. Yeah, I think those are my thoughts. Austin, if you have anything additional, please share. Otherwise, get some more info.
Yeah, no, I think the only thing you touched on again was like, if we invoke the infiltrative hypothesis, again, I'm still sort of surprised by the lack of like overt inflammation. And maybe part of it is because this patient is, relatively immunosuppressed with some of the kind of medical issues that we're dealing with. But at 38, I'll be hard pressed to think about that. The other thing that you've seen a lot more in me is like disseminated histo, which could certainly cause an LDH this high. But I would be stunned by the absence. I guess we haven't received any chest imaging to my knowledge yet, but the lack of any signature on the pulmonary exam, though, is imperfect. And I think we have a relatively robust hypothesis for why the patient has had subacute progressive dyspnea in the form of this anemia. I guess I'm curious, are we missing any sneaky inflammation? And I guess maybe some of that could be in the form of bone marrow infiltration. But if you think about like the portal of entry for the malignant causes of inflammation, those are we basically invoking infection. And oftentimes it's the lungs that are at play. So maybe for funsies, I would get some chest imaging, though I think it probably is like a low yield exercise given the lack of inflammation, though it is something that is kind of stuck in my mind. The other one would be like autoimmune disease. But again, I think which autoimmune diseases could cause this depth of issues without other signs of inflammation? I guess I would say lupus, because lupus can do anything. But realistically speaking, probably not at play in this particular demographic. But the other one is, this is the interesting thing about pernicious anemia, right? Or is that really you're not, it's an isolated problem to the absorption in the stomach in and of itself, and you're not really going to see signs of systemic inflammation. So we'll see if that hypothesis plays out. I think pernicious anemia is like one of the causes of like sky high LDH. I missed a 0 on the initial number, but I think that's interesting thread to pull on. So yeah, excited to learn more from you, Rahul.
Wonderful. We were in the same thought process and we made the similar differentials and wonderful discussion. And now I have fifth aliquot. Ultrasound of the abdomen and pelvis showed borderline splenomegaly, and bone marrow aspiration showed erythroid hyperplasia with megaloblastic maturation. And he also got an upper endoscopy in view of any blood, in suspicion of any blood loss, and it showed grade 1 hiatus hernia with non-erosive esophagitis, gastritis, sorry. And he also got 8 a.m. early morning serum cortisol that came to be 42. It was very low, normal range in the range of 133 to 537. And he also got the antiparietal cell antibodies, IgG, that came with 36. Normal values less than 20, and anti-TPO antibodies were positive. This is the end of my last aliquot, and the next aliquot will reveal the diagnosis.
Okay, excellent. Thanks so much for sharing. So, here we get that the cortisol is low. I would love to know if the patient was stimmed, but based off his autoimmune history, I think, I'm going to invoke the possibility that he has adrenal insufficiency, just to make my thought process a little bit easier. And the prior antibodies being positive is potentially suggestive of pernicious anemia. I guess I would love to know if the stomach was biopsied on the EGD to show if that cause that was like autoimmune gastritis was present, that would also be suggestive of that. And then the sort of the TPO positivity also just points to the idea that the patient likely has Hashimoto's, which makes sense based off the clinical history. We don't see any evidence of varices on the EGD. We only see sort of mild splenomegaly. So really not getting a signature of significant liver disease here. So I think with everything in totality, the patient, and then the bone marrow biopsy, which demonstrated, if I remember correctly, erythroid hyperplasia and megaloblastic maturation, which honestly, I'm not entirely sure how to interpret, but I guess I would just say it's probably related to, his inability to, make the cells properly with his underlying B12 deficiency. Although I find that the MCV being normal is a little bit interesting, although he may just have like multiple vitamin deficiencies that are pulling the size of the red blood cells in both directions and then just sort of meets in the middle. So, I do wonder with the multiple potential autoimmune diseases that this patient now has with the adrenal insufficiency, potentially pernicious anemia, and, the Hashimoto's thyroiditis, if the patient meets criteria for autoimmune polyglandular syndrome, just like Austin had mentioned early on. So yeah, I guess we could prove potentially that the adrenal insufficiency is from an autoimmune disease by sending antibodies. I don't really remember which ones they are. And then I guess I would just be asking myself, if the patient isn't having active hemolysis, is the fact that he just doesn't have the nutrients to make the cells properly, make them fragile enough to produce an LDH that high. And that's would be a gap in my knowledge that I would have to try and figure out, because that's a very elevated LDH. But we don't see a clear evidence of malignancy in the bone marrow. And I imagine flow cytometry was sent off of there that was presumably negative. So I feel like this just plays into the patient's likely multiple nutrient deficiencies, right? Likely related to an underlying autoimmune cause that was leading to malabsorption of them, but and then potentially poor intake related to his alcohol use disorder. But then with the edema, I'm not exactly sure what caused said edema. I don't know if it could have been related to his thyroid disease or if it was related to his albumin being low, although it wasn't really low on the check, or if it was related to something else entirely. But I think that's a thread that potentially be explored in the future, but it's certainly not his main problem. So I think at this time, those are my thoughts. And Austin, I'd love to know how you're tying this together, because it looks like we're almost out of time.
Yeah, no, rich discussion, and that's where my headspace is. Like, I think we have evidence of, multiple autoimmune processes at play, or at least the antibodies. And we also don't really see signs that the bone marrow is infiltrated with anything. So that kind of eliminates that possibility. We didn't see any evidence of like leukemic cells or, primary malignancy. So that's there. So really we're in the space of that there is a substance issue, like there's a deficiency of a substance. And I think we have evidence for that in the bone marrow, but also, maybe the, is there a peripheral reason why we're getting cytopenias as well? I'm not really sure. If I think about how do I explain pancytopenia outside of a true, like you just have you have a factory, but you don't have the stuff to make the things that you make in your factory, is more of these autoimmune diseases of which I think adrenal insufficiency can cause pancytopenia. Rarely. I know there are endocrinopathies. I think more of like panhypopituitarism. I think there's been a case on VMR like a long time ago that invoked that as a possibility. So I'm pulling on that thread. But really, I think, we're in the space that there's multiple autoimmune conditions here at play. And how do I explain the splenomegaly? We're not seeing overt evidence of cirrhosis, though. The scan is an imperfect way to diagnose that. So, I think what we're getting at is there's a hectic picture. There's a chronic background disease, and then there is a subacute progressive chronic, maybe even chronic flare of what's happening here. And we're basically getting a patient that's presenting with an overlap of all those things that we're trying to now reconcile. So the problem we really need to solve is, to start, I would say objectively, is a pancytopenia. Once we have that solved and we address that issue, we need to return back to the dyspnea that the patient has. And, we have a reasonable working hypothesis now why that is. And if we haven't answered that, then we need to kind of revisit what's happening. And I agree, the edema had sort of gotten cast to the side. I'm not exactly sure. Maybe there is a like leak phenomenon to invoke here. That's like, when I get in this space, I'm not really sure, but most of those things are either in the form of a complement mediated process like a TMA, or an infection, which we're not really saying is here, or a cancer of some kind, often a blood cancer, which we're not seeing evidence for, at least to date so far. So yeah, I mean, really amazing case, like really stretched us very far, took us from swelling to dyspnea to pancytopenia, the thyroid disease, all over the place. So yeah, Rahul, amazing case, and tell us more.
Awesome. And I really loved your discussion. And with the given background of pernicious anemia, diabetes, and recent onset diabetes and autoimmune thyroiditis and suspected Addison disease, that we thought it could be a possible autoimmune polyendocrinopathy type 2. We are not sure about why there is edema, and we actually thought of getting an echocardiogram, but the patient was discharged, and they thought of planning with outpatient, but this patient did not follow with us. And also, as Andrew mentioned in one of the chats, that anti-parietal cell antibodies are not specific for autoimmune polyendocrinopathy. We need anti-IF factor 2 and 21 beta hydroxylase antibody and other antibodies for diabetes. Unfortunately, we're not able to get that. But preliminarily, we made the diagnosis of polyendocrinopathy type 2, and we symptomatically treated with all the steroid, thyroid, and insulin supplementation.
Yeah, amazing. Thanks so much. And I guess I meant to mention it last. I'm going to be authentic. Like, what drove you to order a cortisol in this patient?
And because there is a pernicious anemia going on with the young patient and suspected thyroid, so maybe I thought of getting an full full endocrine workup, and with this that drove us to get a serum cortisol
Got
level.
you. Yeah, no, I think it's a brilliant thought. If I think back to the patient clinical presentation, there's nothing that screams to me about adrenal insufficiency, but I think that is the challenge of adrenal insufficiency, is that it is very hard to diagnose and the symptoms can be very subtle. And if we look back at the labs, there was some hyponatremia and the potassium was like slightly on the higher end of normal. So I made note of that in the moment, but didn't really piece those things together until now, or didn't vocalize that till now. So that's an interesting thread. But I have to say, like, you guys are smart, and I think the other thing that's a main takeaway from me is that, you presented a really rich, like, health-related behavior history, and we really focus on the alcohol use disorder. We didn't anchor on it, but you guys did such an amazing job saying, hey, we're going to do this full evaluation. And unfortunately, this is not the case for many patients that have alcohol use disorder or other substance use disorders. They just get cast aside when there is a concern that fits with whatever substance that they use. And so kudos to you guys for really doing a thorough evaluation and understanding these things that really, really change management. And those are my, initial reflections. Alec, what reflections do you have?
Thank you so
I
much.
agree.
Thank you.
And Rahul, that was an amazing case. Thank you so much for sharing. I'll have to do a lot of reading on this. Yeah, like, I'm not sure I really would have picked up the cortisol until later, especially with the blood pressure initially. But yeah, the labs may have been a signature, and I guess I would have loved to know what they were like after he was resuscitated, if that was something that, continued, or if that was something that was new. And then, yeah, I mean, the splenomegaly, I wonder, like, could he have had some extramedullary hematopoiesis? And that's why his spleen was a little bit big, just because his bone marrow was struggling. The edema, certainly, I struggle a little bit, unless, I imagine after he was resuscitated that the albumin went down a little bit. Maybe that was enough. I'm not really sure. But yeah, just an amazing case, and just something that I'll always remember. So thanks very much for sharing. And I think I can pass it to Rahul to see if he has any reflections, and then we can go to Parisa for the teaching points. And thanks so much, Gerardo. So we're keeping up with the with the great presentation.
Thank you so much. And I really want to appreciate Austin and Heemun, but they really came to the diagnosis in the middle of the discussion. And Heemun was actually putting the all the differential diagnosis in the chat. I really appreciate her. And 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 getting a serum cortisol level was something which completely changed that differentials and management. I thought that is one thing. And I really learned about the differences between autoimmune polyendocrine 1 and 2. I just want to quickly go over the 2 or 3 points, if you don't mind. And autoimmune polyendocrine type 1, it's more commonly seen in patients in infancy, but with APS type 2 more in middle to old age, 20 to 60. And yeah, as far as autoimmune polyendocrine type 1 is concerned, the clinical features usually range from hypoparathyroidism, mucocutaneous candidiasis, and Addison's disease. As far as APS type 2, you're going to see type 1 diabetes and autoimmune thyroiditis and Addison's disease as seen in this patient. So those are my learning points from this case.
Thanks so much. Yes, and for all your preparation and this awesome case, and yeah, so much to learn and grow from, and kind of help me refine a lot of different schemas. So thanks so much. And
Thanks
on
so
to Parisa for the teaching points.
Thank you, Rahul. It was an amazing case, and it was a really enriching discussion. I was trying to capture many of the discussion, but it was many. To be mindful of everyone's mind, I will try to just mention some of the teaching points. I think that one of the important point of this discussion was the points of the GI bleeding that are presenting with darker stools and mucosal bleeding, and the causes for that could be peptic ulcer, malignancies, vascular malformation, coagulation disorder like platelet dysfunction and coagulopathies, and we need to perform endoscopy to find out the reasons for that. To approach the patient we had here, we also linked the edema patient had with the GI bleeding, and we were looking for the stigmata of the cirrhosis. We were looking for spider angioma. We were looking for jaundice, telangiectasia, osteoarthritis. We were looking for JVP and the signs of malnutrition like any kind of rashes. We were also looking for conjunctival pallor because it is a really reliable indicator for the anemia, any pallor on the anterior conjunctival rim. And Austin and Alec really found out early that the diabetes with plus hypothyroidism are the autoimmune, could be sign of the autoimmune polyglandular syndrome, and the co-occurrence of the multiple gland involvement could be present, including pancreas involvement and adrenal involvement. It was really interesting that when anemia and the thrombocytopenia are presenting together, we should do not miss the TMA, TTP, liver disease like portal hypertension. We also address the BUN creatinine ratio, which is showing the urea absorption, showing that urea absorption is increasing, and we are having blood in the GI lumen, and the volume depletion is increased. And the other condition are steroid use and catabolic states like in ICU setting. This patient has pancytopenia, and we also discussed that immunosuppressed patient, when we are having high LDH and shortness of breath, they also might have disseminated histoplasmosis. Also, they might not have any respiratory symptom at all. We also need to have think about autoimmune disease like lupus in the back of our mind. This patient have TPO antibodies that was supporting the diagnosis of Hashimoto thyroiditis. We also learned that adrenal insufficiency can cause pancytopenia as well. Thank you, everyone.
Thanks so much, Parisa. Thanks, everybody. Hope everybody has a great day and happy CP Cell.